Good evening, everybody. If I could ask for your attention. Yeah. Thank you. So, my name is Monika Kuczynska. I'm Secretary General of the European Public Health Alliance, and it's my pleasure to be your moderator for the second plenary of the European Public Health Conference 2013, Hurtling Towards the Edge, Population Dynamics and Public Health. And this is a particularly timely moment to be looking at the crises that we face ourselves as public health. We have had a number of discussions in different sessions about the economic crisis. We have had some discussion about the technological crisis, and we've had some discussion about the demographic crisis. We are aging, which is, I think everybody in this room is fully aware of the impact of that on our health systems, whether we can afford them, whether they're fit for purpose. And so the first question that we must ask ourselves is, are our health systems fit for the challenges that we're facing at the moment? And so it's my pleasure and my honor to present to you the keynote speaker for this plenary, Professor Johan Mackenbach from the University of Erasmus in the Netherlands, who will be presenting to us a unique, a fresh and quite extraordinary piece of research that has been undertaken in for the first time, benchmarking all EU member states and their successes and failures in terms of health policy. So, Professor Mackenbach.
Thank you, Monika, and thank you all for coming to this session after a long day of hard work. And I really hope that you will be able to follow my lecture, even if you are in the back of the room. I'm not sure that the size of the projection fits the size of the room, so feel free to come down if you can't read my slides. And as Monika said, this is a presentation on benchmarking countries, or to put it in a more inspirational perspective, on the successes and failures of health policy in Europe. We are all working towards effective health policies, mainly through prevention in public health, but we usually don't have a good idea of how successful our countries are in terms of health policy. And the study that I will illustrate this afternoon aimed to assess the degree to which different countries are successful in their health policies. But let me start by explaining to you what the main reasons for doing this research were. First of all, Europe is an underutilized natural laboratory for policy evaluation. There is so much variation in Europe that we haven't used so far, while there have been enormous variations in population health trends that really provide scope for using this natural laboratory. And while healthcare and social policies have often been studied, health policy in the sense of preventive health policy has not. So that's why this study has been done. But before I come to present the main results of this study, I'd like to present you with a little bit of context to the study, and that context consists of the divergence of life expectancy in Europe, the recent divergence since 1980, 1990 of life expectancy in Europe. And I'll start by giving you some possible explanations for this divergence, and what we will see is that economic and also political factors apparently are behind this divergence, but these economic and political factors don't provide the final answer. What we found is that differences in health policy implementation are certainly part of the final answer of why this divergence has occurred. And I'll show you the results to illustrate that point. And after we've seen these variations in health policy performance, I'll go on by looking at the main determinants of health policy performance. Why have some countries been more successful in their health policy than others? And that's when we return to the economic, the social and the political determinants that we already saw when we looked at the recent divergence of life expectancy in Europe. Let me start by giving you this context of widening gap in health within Europe. And we can most clearly see that when we look at life expectancy and how it has developed over the 20th century. What we see over the 20th century is a pattern of divergence, of widening, mainly in the 1920s and 1930s, then a narrowing, with the narrowest point being reached around 1960, 1965, and then a widening again. A widening, a narrowing, and then a recent re-widening of the gap in life expectancy. And it's not so difficult to find the correlates of this widening, this recent widening of life expectancy. These correlates are both economic and political. The first thing to notice when you look at this widening of life expectancy is that it actually follows the widening of the gap in national income between countries in Europe. When we look across the 20th century at the gap in national income between countries, we see, and that's what this slide shows in terms of the interquartile range of life expectancy and how it's determined by national income, we see a widening of the gap in national income in the 1920s and 1930s, which is translated into a widening of the gap in life expectancy. Then we see the gap in national income diminish in the 1950s, 1960s to reach its lowest point in the century, around 1960, 1970, with life expectancy following that. And after that, both the gap in national income and the gap in life expectancy starts to rise again. So this recent divergence of life expectancy is probably related to a widening gap in national income in Europe, a gap that we clearly see in this type of Preston curves across the 20th century. Even now, there still is an association between national income and life expectancy. Life expectancy tends to be higher in countries with higher national income, and across the last decades, this gap in income has increased substantially, drawing apart life expectancy with it. That's the first part of the explanation of this widening gap in national income. But when you look behind that, you immediately, of course, run against the political determinants of this development. Why is it that the gap in national income has increased? It's not a coincidence. It's not a law of nature that countries in Central and Eastern Europe have become relatively more poor over the past decades as compared to Western Europe. This is a consequence of the political divisions in Europe. It's perhaps a consequence of the decisions taken in Yalta in 1945, when these three gentlemen decided to carve up Europe between a Western and a Central and Eastern European part. And as a result of that, we see this divergence of national income and then life expectancy. And actually, it's possible to see more directly the influence of these political conditions. And I have two examples of illustrations of the direct influence of political conditions. The first is a simple one. We can simply compare countries that were still very similar before Europe was carved up, and that became very different in terms of life expectancy after Europe became divided in a Western and an Eastern European part. And one very nice illustration of that is the difference in development of life expectancy between Finland and Estonia. Finland and Estonia had a very similar level of life expectancy in the 1930s and 1940s. And while Finland continued its increase in life expectancy and a narrowing of the gap with Sweden after the Second World War, Estonia, that became part of the Soviet Union at the end of the Second World War, started to follow the life expectancy trends of the Russian Federation with an increasing gap with Sweden. And it's only since 1990, when Estonia became independent again, that its life expectancy trajectory started to break away from that of Russia and started to follow the path of Finland. This is a very direct illustration of the impact of these political conditions in Europe and how they have influenced life expectancy. And We can actually see much more of that when we look more closely at developments in Central and Eastern Europe after the collapse of the Soviet Union. These are the life expectancy trends of countries in Central and Eastern Europe on the left-hand side, former Soviet Union on the right-hand side. And what we actually see is that countries that went successfully and quickly through democratization, for example, the Czech Republic, had a much more favorable development of life expectancy than countries that went through a slow and hesitating process of democratization like Romania. I'll illustrate it in a moment, but when you do a formal analysis of how levels of democracy relate to life expectancy and cause-specific mortality over time within Europe, what you actually find is that democratization is associated with higher life expectancy, particularly cumulative democracy. The number of years that countries have lived under democracy has a very strong positive association with life expectancy. That is the result of a strong negative association with mortality from all causes, of course. And that, in turn, is the result of a very strong negative association with cardiovascular disease mortality and injury mortality. Countries going through successful democratization see their mortality from cardiovascular disease and from external causes decline, whereas countries that don't do that see their mortality decline much less or even increase. We don't see the same phenomenon for current democracy. When countries go through democratization, there is often a temporary decline of life expectancy due to a rise of mortality from particularly external causes. And we know from many Central and Eastern European countries that during the transition to democracy, this rapid political transition, law enforcement broke down, roads were flooded with new cars, and these chaotic situations have led to this positive association with current democracy in Europe during the process of democratization. But when democratization then builds up cumulatively, it starts to reverse the association and mortality starts to decline. And this can be illustrated graphically for two contrasting examples, the Czech Republic and Romania. The Czech Republic went through democratization very quickly and rapidly, that's the blue line. Cumulative democracy stabilized immediately and life expectancy started to go up rather quickly, whereas Romania went through a more hesitating process of democratization, not full until the 21st century, and cumulative democracy continued to go down, and you see life expectancy having a much less favorable course. So economic conditions and political conditions apparently have influenced or may have influenced the development of life expectancy and cause-specific mortality in Europe over time. But then how did that work? How did economic conditions and how did political conditions influence life expectancy and cause-specific mortality? And I will argue that that was at least partly through health policy. Countries with less favorable economic conditions, countries with less favorable political conditions, including lower levels of democracy, have had less successful implementation of effective health policies. And that result comes from a study that we've conducted over the past 2 years or so, a study that Martin McKee, who is in the room, has also been heavily involved in which we have reviewed 11 specific areas of health policy in Europe, ranging from tobacco control to cancer screening and from child health to road traffic safety. In this study, we have looked at the success of countries in implementing the things that we know that work in each of these 11 areas. And how did we do that? We recruited a large group of experts in each of these fields whom we've asked to do literature reviews, to identify effective interventions. We then try to find measures of the degree of implementation of these interventions or policies and related the degree of implementation to intermediate and final health outcomes. For example, we looked at whether countries that have implemented more tobacco control measures have indeed seen their smoking rates go down faster And finally, their lung cancer rates go down faster than countries that did not implement these measures of tobacco control. And based on these associations that we've seen, we were able to select 27 performance indicators for health policy, covering 10 different areas of health policy. And on the basis of these 27 indicators, we then created a summary score that helped us to rank countries on the basis of their overall health policy performance. And using this summary score, as well as the 27 specific indicators, we then started to look at the determinants of health policy performance. But let me first show you what the results of this study were. The descriptive results. What were the successes and failures of health policy in Europe? And that's actually quite easy to say. In each of these areas, there have been some major successes. We identified effective health policies or programs of prevention in each of these areas. And we saw that some countries have implemented all or almost all of the measures that we know work against these problems. But at the same time, we saw that many countries also have not implemented everything that we know is effective and have failed to achieve the health benefits that are possible with these health policies. The successes and the failures are found in each of these areas, and some countries have been more successful than others across these areas. And before I show you the ranking of the countries, let me illustrate the point that I made earlier, that what we found is that implementing these programs or policies is often associated empirically with better health outcomes, either intermediate health outcomes, such as behavioral changes in the population, or final health outcomes, such as infant mortality or road traffic accident mortality. And I'll show you a few examples. This is the example of tobacco control. Countries that have implemented more tobacco control measures, like higher excise taxes, counseling to help people stop smoking, bans in public places, and so on. Countries that have a higher score on the so-called tobacco control scale, which is on the x-axis here, have seen a stronger decline in cigarette sales. That's what this graph shows. They also have lower prevalence rates of smoking at the moment. They also have lower lung cancer mortality rates at the moment. There is an association between implementing these tobacco control measures and intermediate and final health outcomes. And that applies to many of the areas that we reviewed. This is the area of food policy, perhaps an example that you are less familiar with than with tobacco control. In the past, we've iodized our salt in Europe, but the effectiveness of salt iodization has decreased over time. We have forgotten to implement salt iodization successfully in all kinds of new foodstuffs. And as a result, the penetration of iodized salt in the diet of European populations differs substantially between populations. That's what is on the x-axis, the penetration of iodized salt into the diet of European populations. Countries with more penetration of iodized salt into their diets have a lower prevalence of iodine deficiency, something that perhaps is not widely enough known. We also see that countries that have higher rates of measles immunization due to well-organized programs without financial barriers have less measles epidemics. We see that countries that enforce seatbelt wearing have less car occupant deaths, and so on. So there is really evidence that implementing these policies leads to better health outcomes, which then led us to create these performance indicators. And this is an overall table, not meant to be read, but just meant to be seen from a distance through your eyelids, because what it shows is in the columns the 27 indicators that we have chosen, and in the rows the 42 countries of Europe for which we have been able to collect these indicators. And countries in the north of Europe are in the top of the table, countries in the east are in the bottom of the table, and green indicates that a country is in the upper tertile, the upper third of the European distribution for that particular indicator. Orange indicates that a country is in the lower third of the distribution, and you see clearly that the Nordic countries are almost all green. They do well across these 27 indicators, whereas countries in the east of Europe often do worse, much worse. They are often in the lower tertile of the distribution. And we've used this information on whether a country is in the upper tertile or in the lower tertile of the European distribution to develop a health policy summary score, which measures the proportion of the percentage of indicators for which a country is in the upper third minus the percentage of indicators for which a country is in the lower third. And what we find is that on top is Sweden, followed by Norway, Iceland, Finland, and then the Netherlands. And on the bottom is the Ukraine, the Russian Federation, and Armenia. That is the range of countries with their health policy performance summary scores that we found. And to illustrate this a little bit, without going into too much detail, let me show you the results for Lithuania, one of the countries that is below the middle of the distribution. Lithuania is a country that doesn't do as well as the European average on tobacco control. It also has a higher proportion of daily smokers. It does reasonably well on alcohol control, but it doesn't do well on iodine deficiency. It has a low neonatal mortality, but it doesn't do so well on child safety, and so on and so on. And based on the 27 indicators, or the indicators for which data are available in Lithuania, we found that the summary score for Lithuania was -28, whereas the average for Europe as a whole is 5. Lithuania does a little bit less well than the European average. And you will not be surprised to find that countries in Eastern Europe do less well than countries in Western Europe, but you'll be surprised by some other details in this ranking. For example, what we find is that while Sweden does very well, Denmark does much less well. Denmark is doing definitely worse than its neighbor country Sweden, not only on smoking. I knew before this study was done that the Danes smoke more than the Swedes, but Denmark does also less well on road injury prevention. It also does less well on cancer screening. It does less well on child immunization. There's a whole range of health policy areas where the Danes do less well than the Swedes. And another surprise is the Netherlands versus Belgium. I don't want to be unfriendly to our hosts during this conference, but Belgium comes out quite poorly on this ranking, and certainly much more poorly than the Netherlands, and also in a wide range of areas of health policy. Not only smoking, not only alcohol, also road traffic safety, also cancer screening, and so on. So this is what we found in descriptive terms, these huge variations in health policy performance. And what we also found is that there is a lot of unfinished business here. These countries that have not implemented the policies that we know are effective, where there is this enormous gap in implementation, they can typically reduce up to 50, sometimes even 80 or 90% of premature mortality or other unfavorable health outcomes in their countries. And even in Western Europe, where most countries score well, typically a third to half of years of life lost could be reduced if they would all adopt the policies of the countries with best practices. And this is illustrated in this graph. On the left-hand side is lung cancer mortality, the proportion of potential years of life lost due to lung cancer in each country that could be avoided if that country had the lung cancer mortality rate of Sweden. And that proportion is even 70% in Hungary. 70% of all lung cancer deaths could be avoided if it would have the lung cancer mortality rate of Sweden. And in the Russian Federation, more than 80% of potential years of life lost due to road traffic injuries could be avoided if Russia had the road traffic injury mortality rate of Sweden. Enormous gap in implementation and a gap in mortality as a result. And that applies across the board of all the conditions that we've studied. Now, these are all pretty descriptive results. Let me now move to a few more analytical results. What explains why countries are effective in terms of the implementation of health policies? And what we did in the analysis was to look at differences between countries in their will or in their means to implement health policies. And indicators of the means to implement health policies include national income, for example, or government effectiveness, measures of the effectiveness of the government bureaucracy. Differences in will, for example, levels of democracy or cultural values or the political composition of governments. And what we found in the analysis can be summarized quite simply. Is it a country's means or is it a country's will? It's partly a matter of means. Of course, health policy performance reflects national income and other indicators of will. This graph shows the association between national income and the health policy performance summary score. There's a clear and very strong positive association. Countries with a higher income have a higher score on their health policy performance. But a stronger correlate, a stronger possible determinant is a country's will as measured by its cultural values. We discovered that a country's value orientation, as measured in the World Values Survey, is a stronger determinant of its health policy performance summary score than its national income. And the measure that we've used here is a measure called self-expression or well-being, which has been developed by Robert Inglehart in the context of the World Values Survey, which found that the cultural values, the broad preferences that populations have in life in general, can be described quite well by two dimensions. A dimension contrasting traditional or religious values to secular or more rational values, and another dimension contrasting survival values to self-expression values or well-being values. And it's this second dimension that is a very strong predictor of health policy performance. Countries in which the population is no longer oriented towards mere survival, towards having a roof above your head, but where children are taught by their parents that it's important to be happy in life and to fulfill your own capacities, these countries also have a high score on their health policy performance. And actually in this graph, Sweden, the country that I mentioned previously, is here in the upper right-hand corner, together with the other Nordic countries. This second dimension, not the first one, is the main correlate of health policy performance. And that led me to look in more detail at these variations in cultural values within Europe. This World Value Survey scale of self-expression versus survival is only one of a number of possible variations in cultural values within Europe. Others, such as Geert Hofstede, a Dutch sociologist who has become quite famous for his studies in the IBM Corporation, and Shalom Schwartz, an Israeli sociologist, have also looked at variations in cultural values within Europe, and they have also found quite interesting patterns of variation, and these have been summarized in this graph that presents the correlation of each of a number of different cultural values with longitude and latitude. And values that are here on the left-hand side are more prevalent in Western Europe, and these include self-expression, the one that I've just mentioned, but also a cultural value developed by Hofstede, indulgence, and one by Schwartz, egalitarianism. Whereas in the south of Europe, we find that another cultural value, in this case uncertainty avoidance, is more prevalent, and also power distance, a measure of how well people accept hierarchy in society. And in Eastern Europe, embeddedness, a measure of conservatism, is more prevalent, and in north of Europe, a secular, rational cultural value. And what I found when I looked at the association between this whole set of values and these behaviors, individual and collective, that were also included in the study of health policy performance, I found that self-expression indeed is the most important of these cultural values in terms of explaining these differences between countries in individual or collective health behaviors. Out of 30 different indicators, 15 have a positive association with this self-expression value, and only one has a negative association. Behavior is worse in countries with a higher level of self-expression. But it's not the only value that matters. These Hofstede values are also important, at least for some behaviors. For example, power distance and uncertainty avoidance are associated with less road traffic safety management and with a tendency to prescribe more antibiotics in patients presenting with fever. And then when I return now to what I mentioned previously on the difference between Sweden and Denmark and the Netherlands and Belgium, it actually appears that some of these differences are due to these differences in cultural values. We may think that Danes are similar to Swedes, but when you take these cultural values, they are not. The Swedes have consistently higher scores on self-expression and also on the secular rational scale than the Danes. And when you look at the behaviors that are more favorable in Sweden than in Denmark, it's the behaviors that are strongly associated with these World Value Survey scales. It's this cultural difference between the Danes and the Swedes that probably partly explains the fact that the Danes are doing worse on health policy. And the same applies, but then for other values, to the difference between the Netherlands and Belgium. The Netherlands and Belgium are equally modern on the self-expression and secular rational scales, but they have a very substantial difference in terms of power distance and uncertainty avoidance. Belgium is Southern European in terms of its power distance and uncertainty avoidance, and the health behaviors that are associated with power distance and uncertainty avoidance are less favorable in Belgium than in the Netherlands. All indications that cultural differences between countries are important, an important factor behind these differences in health policy. Now, I'd like to move on now, before I finish, to briefly talk about the role of party politics. That was something that I was very interested in, because I've become interested in the role of political determinants in explaining variations in population health. And there are good reasons to expect that social democratic parties, left parties, are better for population health, for public health, for health policy than right-wing parties. And the reasons are that we know from the political science literature that social democratic parties have been more active to achieve income inequality, or to reduce income inequality, and also to have other collective measures, for example, in the area of social security. And we know that they are less sensitive to business interests, for example, and that's important in some areas of health policy. So I expected countries with more social democratic government, more years of social democratic government, to have more successful health policies. But in the end, in the analysis, it was shown that there is no effect of recent social democratic government, but there is some effect of long-term social democratic government on health policy performance. Let me show that to you. When we accumulate left party or social democratic government over the last 20 years, including Central and Eastern European countries, because they've become democratic around 1990, so they can be included. We can count the number of years of left party government also in Central and Eastern Europe. We have this range of countries. And on the x-axis here, we see the number of years of social democratic government weighted by the proportion of cabinet seats that social democratic parties have in the cabinet in their country. And there's a huge variation between countries. Sweden, the country that comes out best in health policy performance, has, over this period of almost 20 years, 14 years of social democratic government, whereas Malta has only 2. So that's really a huge difference. But there is no association between the number of years of social democratic government and this cumulative measure of health policy performance, as we see on the right-hand side. Perhaps because social democratic parties have adopted neoliberal perspectives in their policies. That's what some people would argue. But when we look back further in time, and then we have to skip Central and Eastern Europe because we cannot count years of social democratic government in these countries before democracy arrived. But we can do that for Western Europe. We again see enormous variations between countries in the number of years of social democratic government. Sweden again in top. In this case, Ireland is at the bottom. We do see a positive association. Countries with a long history of social democratic government have a slightly better health policy performance. And when we look in detail at the specific areas where countries with more social democratic government have been more successful, it's the areas of tobacco and alcohol control. Countries where social democratic parties have been in power for many, many years, over the last 50 years, currently have more tobacco control measures, lower smoking rates, lower levels of lung cancer mortality, and similarly for alcohol policy. So that's an indication that perhaps political factors do play a role here in health policy performance, but you have to be in power for a very long time to have this effect. Let me conclude then. What I started out with was this recent divergence of life expectancy in Europe. And while superficially this seems to be a reflection of economic and political factors, for example, national income differences that have increased and also democratization or slow democratization, behind that divergence is also a big difference between countries in the implementation of successful health policies. The countries that have seen their life expectancy lagging behind are the countries where usually all these effective health policies have not been implemented. And they have been implemented in the countries with rapid improvements in life expectancy. Economic, cultural, political conditions have been the main drivers of this divergence, but these background factors were partly mediated by specific health policies. And I think that's both good news and bad news. It shows us that one can be effective in improving population health. Many countries have been effective, have achieved enormous health gains for their populations, but at the same time there is this enormous implementation gap that we still need to close. And I hope that this study provides some clues to how that might be done. And I'd like to end by encouraging all of you to do this type of study, because Europe's diversity offers these great opportunities for mutual learning that have so far been underutilized. Thank you.
Thank you very much, Professor Mackenbach, for what is a fascinating and unique study into some of the underlying drivers and determinants of our health policy decisions. I think something certainly that many of us are struggling with in terms of take-up and implementation. Before I move to our discussants, there are two questions that I'd like you to hold in mind that I would like to ask you as a part of that conclusion. Can you give us an indication? You hinted at it there in your final conclusion. If you were to give us a recommendation on how we can start to bridge this implementation gap in some of these policies, you don't have to answer now. I'm going to go to the panelists first. Then, what would they be? What would that be from your perspective, having looked at this in detail? And secondly, the issue around the cultural values that shape the behaviours that determine the policies. If we have a clear indication of which cultural values are good for public health, is there a role for public health in exporting these values? Do we have a role as a community in acting as vectors of these values, or is that something that is perhaps ethically, perhaps morally, perhaps technically beyond our reach? So, leaving those two comments, I'm delighted to welcome two panelists who are with us to have the first right of response to that presentation and to ask questions to Professor Mackenbach. So firstly, to my left, some of you will remember him from last year. He was a plenary keynote speaker in 2012. This is Dr. Łukasz Balwicki, a researcher from the University of Gdańsk, who has been instrumental in turning academic research into local advocacy and change. Dr. Balwicki.
Thank you very much, Monika, for giving me a voice. My comment, maybe to what Professor Johann Mackenbach said, is that for the first time, I think I saw a really big picture of determinants of health. And that's, from my perspective, what we lack. This big picture that we have lots of indicators, but we should always take all these indicators when we think of what we should do. Because, for example, from my perspective, from my country perspective, is that sometimes I think maybe even government reads statistics and, for example, looks that economic growth is good for our health. So he supports the industry, and unfortunately, he also supports the industry that is bad for our health, because he picks the cherry that he likes. Yeah? So that's a great work that you did, because that shows that we cannot pick these cherries. We should take all the indicators. And I also have the same impression that Monika as a public health practitioner, is to concentrate on measures, so tobacco control, alcohol policy, and any other traffic accident policy, or should I promote special kinds of political, economic, social values in the setting of every country? So should we be more like a promoting measure, or should we more promote values? Yeah, so that's my comment.
Thank you very much. And our next panelist is Robert Johnston, who is a very well-known and active patient advocate, and I don't think needs much more introduction than that. He is present on the board of the European Patients Forum and on the International Association of Patient Associations. I'm getting that wrong. Robert will correct me in a minute. And from your perspective, Robert, what are your initial reactions and comments or questions to Professor Mackenbach?
Thanks, Monika. Yeah, the second organization that she got muddled on is called the International Alliance of Patients Organizations. And that does what the European Patients Forum does in Europe, but it does it globally. So it's a network of patient organizations. I also found this very fascinating. When I came looking at the title of this topic, I was thinking my role here is to say the way to improve population health, the way to improve health systems, is to say that the patients are part of the solution. They're not, especially those of us with chronic conditions who use the system a lot, rather than seeing us as the problem, the biggest cost in society, those who are least able to help themselves, to turn it round. And it's very interesting because what the professor was saying there is that some of the things about happiness and fulfillment, what people experience, whether they're contributing to what goes on in their lives, whether they have any choice and power, that seems to be one of the determinants for more success. And effectively, this is what I have observed in healthcare systems around the world, allowing for very different cultural values in some parts of the world, but where patients see that health is something that they can participate in, that they can manage for themselves, that they can become involved in a process, not only for their own lives, but perhaps initially those of their family, their friends, other members of a similar population health condition group, that where they experience some degree of satisfaction and change, then that impacts on the society and the health of that society. So that, in a sense, I would pick that point out as something to reinforce, what I wanted to say. But I did find it very interesting. I can understand why, as a measure, we were comparing life expectancy as the sort of key indicator. But one of the other things I would want to say is that I don't like this reliance on life expectancy, because I think it's not just the length of life that we live, but the quality of life. And I'd like to look at this sort of thing again, looking more at morbidity issues rather than life expectancy issues. I suspect we might get the same results, but I'd be very interested if those studies could be done. I mean, I would say that, wouldn't I? Inverted commas, I'm declaring an interest. I have a chronic condition. I've lived for 57 years with that condition. I probably cost the British economy a huge amount of money because it wasn't identified early enough, it wasn't treated early enough, it was treated with wrong systems which caused as much damage as actually the condition was causing. But if we look at those issues, I think those are also extremely important. So I think I'll just leave it at that from now. Thank you.
Well, thank you for these comments and questions. And let me start by one fundamental question, which actually was raised both by Monica and by Lukáš. And that is, now that we have discovered somehow that cultural values are part of the explanation for variations in health policy performance, does that tell us that we can not do anything, or does it tell us that we can do something by influencing cultural values? And this is really a hard question. The main reason why we looked at these cultural values was that we wanted to find some fundamental explanation for these differences between countries. And I think it's inevitable when you start looking for such fundamental explanations that you end up with factors that are very difficult to influence directly from the public health sector. We've seen that in other areas as well. And I don't think that it's within our power as public health professionals to change the cultural values of whole populations. What we do see, however, is that although these cultural values are important determinants of health policy performance, they don't explain everything. And at a particular level of scores on these cultural values, there is still a lot of variation in health policy performance. So even if a country has a relatively low score on this self-expression scale, a lot can be done to improve population health. What we also see is that there is a gradual convergence over time in these cultural values. So they are not immutable. They change slowly over time. And actually the scores on this self-expression scale, they tend to follow with some delay economic growth and economic modernization. So when countries succeed in getting onto a path of economic growth in time, their cultural values will follow. So that's at least a partial answer to your questions on this particular point. Then another question that was raised was, what can be done to close this implementation gap? And I think the answer is actually quite simple. There is really so much in the area of, let's say, alcohol control that can still be done in many countries. There is 4, 5, 6 different measures of which we know that they are effective and that they are cost-effective in reducing alcohol-related harm. And perhaps 1 or 2 countries have implemented them all. Most countries in Europe have implemented them only partially. We should advocate for full implementation of the things that we know that work. And we should spend our energy on trying to achieve that. And let me end by responding briefly to the point made on life expectancy as a measure that has its limitations, and I'm the first to agree that it has. It's still convenient because we have good data on life expectancy, we have not so good data, although it's improving on healthy life expectancy, but we certainly don't have good trend data for many countries on healthy life expectancy. But the analysis of health policy performance included several measures outside the range of mortality, so we haven't limited ourselves to mortality and life expectancy only.
Thank you very much. And can I push you on that? Did you find any correlations between, for example, morbidity indicators and some of these issues? Was there an overlap? Yeah.
Well, in Europe as a whole, there is a very clear positive association between life expectancy and healthy life expectancy. The countries with high life expectancies also tend to have high healthy life expectancies. And we don't have comparable measures between European countries for specific aspects of morbidity, perhaps with the exception of cancer incidence or so. And we've also included cancer incidence in this data set. And we find similar results.
And I wanted to push you on your previous answer, which is that no, that public health doesn't necessarily have a specific role in promoting cultural values. Because your follow-up point was, well, we need to advocate for the measures such as alcohol control, where we know full implementation would have a significant impact. But if I play devil's advocate, if we are advocating for a policy where the national political will and a national public debate is not such where that is acceptable, then is that an efficient use of our resources? And I want to push you a little bit further. So, for example, one of the trends that I've seen in the UK setting, which I hadn't been able to fully understand until I saw your presentation today, and that is that there are a number of think tanks in the UK who are funded from the alcohol industry and the tobacco industry, who are recently investing in student movements and youth movements under the banner of liberty and libertarianism. And I could see these actors who I recognize as industry fronts who I come up against in my normal professional engagement. And I was wondering, I recognize this as a warning, because I thought, well, if these groups, if the tobacco industry is interested in supporting, promoting student groups that are self-organizing under certain cultural values, then they are shaping the decision makers of tomorrow, today. We don't do that. Should we do that? That goes beyond advocating for the implementation of policy mechanisms. That goes towards fostering a society and a culture that is respective of the values that we are promoting as a sector, as a public health sector.
No, and I didn't mean to say that we should refrain from trying to influence people's attitudes, but I answered to the question whether we can influence cultural values in the sense that I used that concept in my presentation, which is something rather fundamental and slowly changing over time. I'm not aware of any intervention method that can influence these very basic cultural values. But we know that we can influence people's attitudes towards tobacco, and the tobacco industry, like you just alluded to, has effectively manipulated people's attitudes towards smoking, and we can do the reverse. So I think we really need to also address these attitudes in order to provide a fertile ground for our policies and interventions.
Yes, in terms of cultural values, I mean, in a sense, this is something we come up a lot, not so much in the European Patients Forum, but the International Alliance, because, you know, when you're meeting patient groups from India or from Africa, they're coming from such a different background. Not only is the income level much lower, but the social values are much more, you know, much more, shall we say, old-fashioned, patronizing attitudes between doctors and patients. And what we feel is that we can't impose the Western model, but what we can show the benefits of it, the success that it can bring. And then if we do go into one of the third world countries and organize a regional event and so on, We also like to, being good egalitarian Western European model, we like to sort of learn something from their culture, which we feel we should be bringing back to the West. And sometimes these, although they're coming from a much more traditional, old-fashioned attitude very often, much more survival-orientated, it's interesting how much happiness and fulfillment some of those countries are getting in their population, and how much support of traditional family values and communities and so on is working. So I think it seems to me we need a blend of all these things. And I just have to tell you one story from Pune in India, because I thought this was quite interesting. When I was there as part of a group a few years ago, we thought we should do something practical for the people of India and for public health while we were there. So we got some sponsorship to get some free motorcycle helmets. And the whole course went out based at a local hospital. We had all this organized. The police brought all the motorcyclists off the road as they went past the hospital, the ones who weren't wearing helmets. And we all lined up with our helmets to give to the people who weren't wearing helmets as they went past. And, it was a very interesting thing to do for a couple of hours under the hot sun, and all these people coming past. But, and we were trying to influence a change in behavior, the wearing of the helmets, the campaigning for helmets and so on. And we gave out quite a few, including one pair of young ladies on a scooter who came past 3 or 4 times getting as many helmets as they could so they could sell them to their friends. But apparently what happened was that there was a policy change shortly after we left, and the government did enforce the wearing of helmets. But then apparently what happened was the population rebelled, and there were demonstrations in the streets, and the government withdrew the legislation. So we are talking about very different societies. I think that's all I wanted to say on that.
Thank you, Robert. We're unfortunately out of time, so I wanted to give the last word to Professor Mackenbach. I think there's a lot of food for thought in what we've just heard, and like all good research, it raises more questions for us to go on to.
Well, in one sentence, go home and finish this business of closing the implementation gap.
Brilliant. Thank you very much, and thank you for staying with us. It's fascinating. That must have been a really interesting piece of work to do.